Everybody, this is Saeed and welcome to new episode 10. This is about the book Handbook of COVID-19 Prevention and Treatment. This book is a protocol and guideline for the hospital for one of the hospital in China. The hospital name is Zhang University Hospital, and the author and editor for this book is Professor Tingbo LIANG. I want to thank him and his team for this effort. I was waiting for such a thing from China, so this is the first book I saw, and I want to transfer this experience to a PowerPoint presentation so everybody can listen to it while driving. Because reading a book maybe it will take time, but maybe listening while driving it will be helpful. So today we'll talk about TCM. TCM means traditional Chinese medicine, what they use in their hospital, and drug use management of COVID 2019, the medication, the management. So, traditional TCM, traditional Chinese medicine classification therapy to improve curative efficacy, classification, and stage. COVID-19 can be divided into early, middle, critical, and recovery stage. At the early stage, the disease has two main types, wet lung and external cold and internal heat. The middle stage is characterized by intermittent cold and heat. The critical stage is characterized by internal block of epidemic toxin. The recovery stage is characterized by QI deficiency in lung spleen. The disease initially belonged to wet lung syndrome due to fever. Both intermittent cold and heat treatment are recommended. In the middle stage, cold, dampness, and heat coexist belong to cold heat mixture. In terms of TCM, actually, I don't have any experience with traditional medicine, just I'm reading for you whatever they are saying. Both cold and heat therapy should be considered. Both cold and heat therapy should be considered according to the theory of lead to cold spleen and stomach and cold heat mixture in the middle. Therefore, in this stage, both cold and heat therapy should be considered because cold heat symptoms are commonly seen in COVID-19 patients. The cold therapy is better than other approach. Therapy-based classification: wet lung, ephedra, herb 6 gram, semen, armin, arminash, amram gum, cocax. This is a lot of requirash, etc. So this you can go through it. I don't have any information about this um, Chinese medicine. External cold and internal heat. Again, this list of medication, Chinese medication, herbal medication. Intermittent cold heat. This is the list. Internal block of epidemic toxin. Use Schwingman for treatment. QI deficiency of lung, spleen. Again, this is big list of herbs. COVID-19 patients are often complicated with underlying. Now we'll talk about drug use management of COVID-19 patient. COVID-19 patients are often complicated with underlying disease, receiving multiple type of drug. Therefore, we should be more attention to adverse drug reaction and drug interaction, so as to avoid drug-induced organ damage and improve the success rate of treatment. Identification of adverse drug reaction. It has been demonstrated that incidence of abnormal liver function 51.9 in COVID patients who have received lopinavir/ritonavir combined with aripiprazole, umifenofir antiviral treatment. Multivariate analysis revealed that antiviral agent and more concomitant medication are two independent risk factors for abnormal liver function. Therefore, monitoring of the adverse reaction should be strengthened. The unnecessary drug combination should be reduced. The main adverse reaction of antiviral agents include for Calitra, which is labinavir, ritonavir, and darunavir cabocistat. Both can cause diarrhea, nausea, vomiting, and the increase of aminotransferase. Jaundice, dyslipidemia, the increase of lactic acid. Symptom will recover after drug withdrawal. Arbidol, which is omifinovir, the increase of serum aminotransferase and jaundice. When combined with leponavir, the incidence rate is even higher when combined together. The symptom will recover after drug withdrawal. Sometimes slowdown of the heart could be induced. Thus, it is necessary to avoid combination of arbidol, which is imifinavir, with beta receptor inhibitor such as metoprolol or propranolol. We suggest to stop taking the drug when the heart rate is below 60 per minute. Favipiravir, elevation of plasma uric acid, diarrhea, neutropenia, shock, fulminant hepatitis, acute kidney injury, adverse drug reaction. The adverse reaction were commonly seen in elderly patient or for patient complicated with cytokine storm. Chloroquine phosphate. For chloroquine phosphate, which is I think wide available in the market, dizziness, headache, nausea, vomit, diarrhea, different kind of skin rash. The most severe adverse reaction is cardiac arrest. The main adverse reaction is the ocular toxicity. The electrocardiogram need to be examined before taking the drug. The drug should be prohibited in patients with arrhythmia, conduction block, retinal disease, and hearing loss. Some antiviral and antibacterial drugs use therapeutic drug monitoring (TDM). There is a table in the next slide present the plasma concentration of the drug and their dosage adjustment upon onset of aberration of plasma drug concentration. The treatment regimen needs to be adjusted by considering the clinical symptom, concomitant drug, and concomitant drug. So, for leponavir, ritonavir, peak 30 minutes after drug concentration, and trough 30 minutes before drug administration. The trough should be more than 1 microgram per ml, while the peak should be less than 8.2 microgram per ml. Correlated with adverse efficacy and side effects. So we need here to the trough to be more than 1 to guarantee its effectiveness, and to guarantee here we need the peak to be less than 0.82 to avoid side effect. Imipenem we don't have it, and meropenem we have it, but we are normally we don't have levels. But here the first time I saw there is a level 1 to 16 microgram, while for imipenem 1 to 8 microgram per ml. Interpretation and just the plasma concentration based of minimum inhibitory concentration, maybe to reach above 4 times above minimum inhibitory concentration of the vaccine testing. Vancomycin 30 minutes before drug administration. You need to reach the level 10 to 20 when it's severe infection. Maybe you need to go to higher, especially if MRSA or patient have central nervous system problem. So you need to give higher dose 15 to 20. The trough concentration correlate with the failure rate of anti-infection therapy and renal toxicity. When the concentration is overly high, reduction of the drug frequency or single dose is required. And this would also applicable during dialysis, only single dose after dialysis, and you need to take the level. Linezolid 30 minutes before drug administration, 2 to 7 microgram per ml. Again, linezolid we are not doing the level in our in most of Arab countries. I don't know in UAE at least. I don't know in other country. Fluconazole 30 minutes before drug administration, 1.5 to 5 microgram per ml. The trough concentration correlate with the therapeutic efficacy and adverse reactions such as impaired renal function. Antiviral drugs such as lopinavir, ritonavir are metabolized through enzyme cytochrome 3A1 in the liver. When the patient receiving concomitant medication, the potential drug interaction need to be carefully screened. Next table show interaction between antiviral drug and common drug for underlying disease. Lopinavir, ritonavir, when combined with drug associated with cytochrome P34, such as statin, immunosuppression agent like tacrolimus or fluconazole, the plasma concentration of the combined drug may increase, leading to 153%, 5.9-fold or 13-fold increase of the AUC of rivaroxaban, atorvastatin, midazolam, respectively. Pay attention to clinical symptoms and apply the TDM. Combined use with amiodarone may lead to fatal arrhythmia, coitabine, severe coma, simvastatin, rhabdomyolysis is prohibited. Darnavir cobicistat, when combined with the drug associated with cytochrome 3A and cytochrome 2D6 metabolism, the plasma concentration of combined drug may increase. See above, because this cobicistat and ritonavir are booster. They are enzyme. They inhibit they inhibit the liver excretion for this medication, so increase its concentration, and it may increase the concentration of other drug. The other one medication, which is Arbidol, I think it's Chinese medication available in the Chinese market. I'm not sure if it's available in other market. Omavinavir, it interact with cytochrome 3A4, UGT1A9 substrate and inhibit and inducer. So any medication metabolized by this enzyme, you have to be careful during co-administration. Vablivir, there is drug interaction with theophylline, increase the availability of vabilovir. It increased the availability of acetaminophen by 1.79-fold. Its combination with pyrazinamide increased the plasma uric acid level. Its combination with ribaglinide increased the plasma ribaglinide level. Chloroquine phosphate prohibit to combine with drug that may lead to prolonged QT interval, such as moxifloxacin, azithromycin, and amiodarone. Avoiding medical damage in special population. Special population include pregnant women, patient with hepatic and renal insufficiency, patient supported by mechanical ventilation, patient undergo continuous renal replacement (CCRT), extra extracorporeal membrane oxygenation (ECMO). The following aspects need to be noted during the administration. Pregnant woman. Lopinavir, ritonavir tablet could be used. Favipiravir and chloroquine phosphate are prohibited. Patients with hepatic insufficiency, drugs that are excreted and changed through the kidney are preferred, such as penicillin and cephalosporin. On the other hand, patients with renal insufficiency, including those with hemodialysis, drugs that are metabolized through the liver or excreted through the liver-kidney double channel are preferred, such as linezolid, moxifloxacin, ceftriaxone. Patients undergo CCRT for 24-hour vancomycin. The recommended regimen is loading dose 1 gram and maintenance 0.5 gram every 12 hours. For imipenem, the maximum daily dose should be not exceed 2 gram because this is CCRT continuous. That's it for today. Thank you very much, and see you next episode. Next episode, we will talk about psychological intervention with COVID-19 patient and then rehabilitation therapy for COVID-19 patient. Thank you very much. Please share this with your friend, and hopefully you will get benefit from this episodes. Thank you very much again.